The thrombin time involves only the addition of thrombin to citrated platelet-poor plasma. Therefore, it is a measure of the conversion of fibrinogen to fibrin. It is also sensitive to the presence of inhibitors that may be present in the plasma, like heparin. The reagent is thrombin. Historically, thrombin was bovine-sourced, but currently human thrombin is used. The concentration is pretty low at only 5 NIH units per mil. NIH stands for National Institutes of Health. One NIH unit is equivalent to 1.1 to 1.3 international units of thrombin. The reagent is pre-warmed to 37 degrees and must be used after 3 minutes, but within 10 minutes of incubation because the reagent deteriorates with incubation. It is added directly to undiluted patient plasma. The reaction occurs at 37 degrees and is measured in seconds. The thrombin time is often performed along with the APTT as part of a mixing study. It may also be performed to determine if heparin is present when the APTT is prolonged. Thrombin time may be prolonged in cases of hypofibrinogenemia, with fibrinogen levels under 100 milligrams per deciliter, and dysfibrinogenemia. Other causes of a prolonged thrombin time include heparin, fibrin degradation products, or FDPs, and paraproteins, which are present in multiple myeloma. The reference range for the thrombin time is less than or equal to 21 seconds. The clot-based assay for fibrinogen activity is actually a modification of the thrombin time called the Kloss method. Like the thrombin time, it measures the conversion of fibrinogen to fibrin, but however, the reagent is about 10 times more concentrated than in the thrombin assay. At about 50, that's not about, it's at 50 NIH units per mil as opposed to 5 NIH units per mil. Platelet-poor plasma is diluted 1 to 10 with a buffer called Oren's buffer. The purpose of the dilution is to minimize the antithrombotic effects of heparin. You can do this at up to 0.6 units per mil. It also helps to minimize the antithrombotic effects of FDPs at up to 100 micrograms per mil, and also control proteins. Again, like the thrombin time, the reaction occurs at 37 degrees and is measured in seconds. Calibrators are used for comparison, and a calibration curve is prepared that converts clotting time to actual fibrinogen concentration. The concentration of fibrinogen is inversely proportional to the clot time. The reference range is 220 to 498 milligrams per deciliter. The most common reason for low fibrinogen levels is DIC. You should expect a prolonged PT and APTT with hypofibrinogenemia. This is an example of a fibrinogen assay calibration curve that allows the clotting time to be converted to fibrinogen concentration. It looks a little quirky, but remember that the concentration of fibrinogen is inversely proportional to the clot time. The calibration curve needs to be updated fairly frequently, at least every 6 months, or when there is a change in the lot number of reagents, or when instrument maintenance has been performed. The activated clotting time, or ACT, is a point-of-care test that is usually performed on patients that are in the ICU or CCU following cardiovascular or vascular surgery, and patients undergoing extracorporeal membrane oxygenation or ECMO, cardiac catheterization, and hemodialysis. The ACT requires a whole blood sample. The instrument combines the sample with a clot activator, which is then mixed with a magnet. When a clot forms, it is detected by either mechanical or electrochemical means. Mechanical detection is based on the movement of a metal ball between two magnets within the sample. Fibrin formation restricts the movement of the magnetic ball, resulting in an endpoint, which is recorded as the clotting time. Electrochemical methods of detection are based on amperometry. Two electrodes are placed in a reaction vessel containing the patient's sample. The timer starts when the clot activator is added to the patient's sample. Detection of an increase in electrical impedance between the electrodes indicates fibrin formation and stops the timer. The reference range is 70 to 180 seconds. Mixing studies can be performed on patients who exhibit an unexplained prolonged PT or APTT. They are used to detect factor deficiencies and specific factor inhibitors. The test requires mixing equal parts of patient plasma and normal pooled plasma. Then the PT or APTT is repeated. If the PT or APTT is corrected, the patient likely has a deficiency of one or more clotting factors, and the next step is to perform single factor assays to identify the specific factor or factors that are deficient. However, if the PT or APTT is not corrected, the patient may have an inhibitor. The mixed sample is then incubated at 37 degrees for 2 hours and the test repeated. If the results following incubation are even further prolonged, the likely culprit is a factor VIII inhibitor. This is because factor VIII inhibitor is an IgG antibody. Of course, there are limitations with mixing studies. The PT or APTT results may not be corrected in patients with a severe factor deficiency or if they have multiple factor deficiencies. This in turn may lead to the suspicion that a factor inhibitor is present, which would be a false assumption. On the flip side, though, patients who have a weak inhibitor present will often show corrected results if with a mixing study, which would lead to the suspicion of a factor deficiency, which would also be a false assumption. Single factor assays may be part of the testing process to determine the cause of an unexpected prolonged PT or APTT. They're done after mixing studies have been performed and a deficiency of one or more coagulation factors is suspected. Factor assays are able to identify specific factor deficiencies. Think of mixing studies as being part of the screening test, while factor assays are confirmatory tests for specific factor deficiencies. The test itself involves performing a PT and APTT, except that plasma known to be deficient in a specific factor type is combined with the patient's plasma. By comparing the resultant time to a standard curve, the percent of activity and amount of correction with normal plasma determines the specific factor deficiency. So, for example, to identify a factor 1 or fibrinogen deficiency, a modified thrombin time is performed using patient plasma mixed with factor 1 deficient plasma. If the thrombin time is prolonged, or it does not correct, the patient has a factor 1 deficiency. Other factor deficiencies are tested for in a similar manner, except the PT or APTT is performed instead of the thrombin time, depending on whether the factor being tested for is an extrinsic or an intrinsic factor. If the factor is part of the common pathway, either the PT or APTT is performed. Testing requires a two-step process. First, 1 part normal plasma is mixed with 1 part factor deficient plasma. Next, 1 part of patient plasma is mixed with 1 part factor deficient plasma. Both samples are then tested and the clotting times are determined. The sample containing normal plasma and factor deficient plasma is expected to show a normal clotting time, because the normal plasma should compensate for the factor deficient plasma. This sample can be considered a quality control of sorts. The sample containing the patient plasma and factor deficient plasma is tested next. If the clotting time is normal, then the patient is not deficient for that specific factor. However, if the clotting time is prolonged, the patient has a deficiency of that specific factor. Factor 13 deficiency is very rare, occurring in only 1 in 1 5 mil. I'm sorry, occurring in only 1 in 5 million births. Patients that have a factor 13 deficiency will have a normal PT and APTT. Therefore, the typical procedure used is to test for other factor deficiencies will not work here. Factor 13 deficiency can be tested for by ELISA or by the following procedure. You add thrombin and calcium to citrated patient plasma. You remove the clot after it forms and place it in a clean tube. Then add 1 ml of 5 molar urea to the clot. Incubate at room temperature for 24 hours and then observe if the clot has dissolved. If the clot dissolved, the patient has a factor 13 deficiency. But if the clot remains, the patient does not have a factor 13 deficiency. The platelet count is a quantitative measurement. You guys should refer to your hematology notes and review both manual and automated methods. As I mentioned before, the bleeding time is an antiquated test that was used to screen for von Willebrand disease and other abnormal platelet functions. The IV method is the traditional method used for this test. While both the IV and the Duke method require the use of a blood pressure cuff, the IV method is more invasive than the Duke method, requiring an incision on the ventral side of the forearm, whereas the Duke method involves puncturing either the earlobe or finger with a lancet. For the IV method, the blood pressure cuff is placed on the upper arm and inflated to 40 millimeters of mercury. A lancet or scalpel blade is used to create a standard-sized incision that is 10 millimeters long and 1 millimeter deep on the underside of the forearm. Every 30 seconds, filter paper is used to draw off blood without disturbing the incision, which could disrupt the clot and falsely prolong the bleeding time. The test is finished when bleeding has stopped. The time from when the incision was made until all bleeding has stopped is measured and is reported as the bleeding time. Theoretically, a prolonged bleeding time could signify a functional platelet disorder like von Willebrand disease or a vascular disorder such as vasculitis. However, the predictive value for the bleeding time is inadequate as it is affected by extraneous non-platelet variables such as skin thickness, intracapillary pressure, and the size and depth of the incision. It has since been replaced by the closure time. The closure time assesses platelet function in vitro by simulating high shear conditions that are similar to those found in vivo. Since platelets play a critical role in primary hemostasis, abnormal platelet function may result in easy bruising, frequent and heavy nosebleeds, and heavy periods. Platelet disorders can be inherited, acquired, or drug induced. The PFA 100, or Platelet Function Analyzer 100, is an instrument that simulates platelet adhesion and aggregation. The instrument requires a cartridge that contains a membrane with collagen and epinephrine and another with collagen and ADP. Platelets from the patient's sample will adhere to the membrane and aggregate, resulting in occlusion or closure of the central aperture. The time to closure is measured in seconds. This is just a picture of the Siemens PFA 100 analyzer. The closure time is used as a screening test for von Willebrand disease and can also be used to monitor desmopressin therapy in preoperative patients. Desmopressin is a medication used to treat diabetes insipidus, bedwetting, hemophilia A, and von Willebrand disease. The sample is whole blood. Limitations include low platelet count and low hematocrit. In addition, mild platelet dysfunction may not be detected. The PFA test is first performed with the collagen epinephrine cartridge. If the results are normal, which would be less than 180 seconds, platelet function defects can be excluded. If the results are prolonged, though, which would be greater than 180 seconds, the collagen ADP cartridge test is then performed. If those results are normal, which would be less than 120 seconds, aspirin-induced platelet dysfunction is the most likely cause. However, if the results are greater than 120 seconds, the cause may be due to one of the following: anemia, which would be a hematocrit less than 28%, thrombocytopenia with a platelet count less than 100,000, platelet function defect other than aspirin, von Willebrand disease, or it could be inherited or acquired platelet dysfunction that can be caused by uremia, liver disease, again von Willebrand disease, or overdose of aspirin. Coagulation quality control should include two levels of QC, one normal and one abnormal. It should be ran every shift or at least every 8 hours. And for discrete or individual runs, these two levels of QC should be ran with each and monitor temperatures, lot numbers, as well as expiration dates of reagents.